Hello, my dear students. So let's have a look at today's quiz questions. Now, the first question which I gave you was on rapidly and slowly adapting receptors. So the first point is, what is adaptation? Now, adaptation means that the stimulus is present, but the response of the receptor has reduced over a period of time. And if this adaptation takes less time, we call it a rapidly adapting receptor. If the receptor takes a longer time for adaptation, we call it a slowly adapting receptor. Now, proprioceptors, these are typically slowly adapting receptors. So let's have a quick look at which are the rapidly and which are the slowly adapting receptors. Rapidly adapting receptors are Pacinian corpuscles. Now, Pacinian corpuscles are very rapidly adapting receptors. They are meant for fast vibration up to 800 cycles per second. They are also meant for deep pressure, which is poking. Meissner's corpuscles, these are meant for fine, well-localized touch. They are also meant for texture, for topognosis. They are meant for slow vibration, and they are very importantly meant for braille reading. What is braille reading? Braille is a script for the visually challenged. It's a special script which has got elevations and depressions, and the Meissner's corpuscles, which are abundant in the fingertips. 60% of the sensory input from the fingertips is from the Meissner's corpuscles. So these are involved in braille reading. Hair end organs which detect light movement on the skin. They are meant for light motion on the skin. Slowly adapting receptors, Merkel's discs, for fine, well-localized touch. These are very important in two-point discrimination. Ruffini's endings. Ruffini's endings are also for fine, well-localized touch and for prolonged pressure. C mechanoreceptors for crude touch and for pressure. The proprioceptors, which are the joint capsule receptors, the muscle spindles, the Golgi tendon organs, these are for joint and position sense. These are slowly adapting receptors. Thermoreceptors for warm and cold sensation on the skin, and nociceptors, which are free nerve endings for pain. So let's have a look at the next question. Now this says, the slowest conduction velocity is seen in which of the following nerve fibers? Now, motor fibers are very large diameter and myelinated fibers. These are A alpha and A gamma. Large diameter sensory fibers are A beta and A delta. These are large diameter and myelinated. Preganglionic autonomic nerve fibers are type B and postganglionic are type C. The Erlanger and Gasser classification divides the nerve fibers into A, B, and C. A is further subdivided into A alpha, A beta, A gamma, A delta. A and B are myelinated fibers, and C is an unmyelinated fiber. So as we go from A to C, there is a decrease in diameter and a decrease in the conduction velocity. So the answer to this question becomes pretty simple. This is the postganglionic autonomic nerve fiber, which is type C. Let's have a look at the third question. Now there's a little catch in this question. If the question said dopaminergic neurons, then my answer would have been substantia nigra pars compacta. But I have asked you dopaminergic receptors. Now these will be present on the striatum. Remember, in Parkinson's, it's the nigrostriatal pathway which is going to be affected. The dopaminergic neurons of the substantia nigra pars compacta project to the striatum. So receptors will be present on the striatum, and there are two types of receptors, D1 and D2, which are present on the striatum. So you can see these. This is the substantia nigra pars compacta neuron, which projects to the striatum, and it will release dopamine here, and the D1, D2 receptors will be present on the striatum. Let's have a look at the next question. This says, there's a shrapnel injury to the upper cervical cord affecting the lateral part of the dorsal column. Now, if you look at the diagram, now in the dorsal column, the medial most are the sacral fibers, then the lumbar fibers. Sacral and the lumbar fibers form fasciculus gracilis. Lateral to the lumbar fibers are thoracic, and the laterals most will be cervical. Thoracic and cervical fibers form fasciculus cuneatus. Remember, C for cervical, C for cuneatus. Now, going back to this question, if the lateral part is affected, that means these fibers or the fasciculus cuneatus will be affected. That means the dorsal column carrying sensations from the same upper limb, that is the arm. So ipsilateral proprioception of the arm will be affected. Why did I say ipsilateral? Because please remember, the dorsal columns will cross over to the opposite side at the level of the medulla. This, we are talking of a spinal cord injury affecting the lateral part of the dorsal column. And lateral fibers are thoracic and cervical. Fasciculus cuneatus. Thoracic and cervical fibers will carry impulses from the upper limb. So ipsilateral proprioception of arm. Dorsal column carries fine touch, localization, vibration, conscious proprioception, stereognosis. These are all carried by the dorsal column. Let's look at the last question. This says there is a right below knee amputation. Now, please remember the sensations from the right half of the body will be represented in the left sensory cortex. So the answer can either be B or it can be D. Now, this phenomenon of phantom limb can be explained by the cortical plasticity. What is cortical plasticity? There is a remapping in the sensory cortex. Now, you know that the entire body is represented in the sensory cortex. More sensitive areas like the face, the hand, and the fingers have very large representation in the sensory cortex. Now, as you can see, this is the leg and the foot area following a right below knee amputation. So in the left side, the leg and the foot area in the left sensory cortex will not receive any impulses. So now what happens is that neurons of the trunk and the hip area, adjacent areas in the sensory cortex, will project and form new synapses. That is what is called remapping or cortical plasticity. So going back to my question, right below knee amputation will affect the left sensory cortex, and what will happen here? The projection of fibers from the adjacent areas to the leg area in the left sensory cortex. Which of the following tracts carries fine touch and vibration from the lower limb? Now, fine touch and vibration are carried by the posterior columns. And posterior columns are fasciculus gracilis and fasciculus cuneatus. Now, when you look at the posterior columns, the fibers from the lower half of the body are present medially. The sacral fibers are the medial most. Lateral to sacral are lumbar, lateral to lumbar thoracic, and the lateral most will be cervical. Sacral and the lumbar fibers form fasciculus gracilis, and thoracic and the cervical fibers form fasciculus cuneatus. So from the lower limb, it has to be fasciculus gracilis. Now, let's have a brief look at all the sensations carried by the different sensory tracts. Dorsal column, fine touch, localization, vibration, two-point discrimination, conscious proprioception, and stereognosis. And when you look at the spinothalamic tracts, two spinothalamic tracts, lateral and anterior. The lateral spinothalamic tract is meant for pain and temperature. Anterior spinothalamic tract for crude touch, itch, tickle, sexual sensations, and baroganosis. Baroganosis is detection of pressure. Let's have a look at the next question. A 35-year-old male presents with weakness of the right lower limb and loss of pain and temperature in the left lower limb following a stab injury to the right side of his thoracic spinal cord. That means he has ipsilateral muscle weakness and he has contralateral loss of pain and temperature below the lesion. Which of the following is the most likely explanation? And this, as you can imagine, is for the Brown-Séquard syndrome or hemisection of the spinal cord. There are both motor and sensory symptoms in this patient. Now, in a hemisection of the spinal cord or the Brown-Séquard syndrome, how do we remember the features? Number one, remember bus stop. In Brown-Séquard syndrome, temperature and pain of the opposite side will be lost below the level of lesion. All the problems will be below the level of lesion. Touch is going to be least affected. Why is touch least affected? Because it is carried by, fine touch is carried by the same side posterior column and crude touch by the opposite side anterior spinothalamic tract. All other sensations refers to the posterior column sensations will be lost on same side. So there is going to be ipsilateral loss of vibration, conscious proprioception below the level of lesion. 4. Motor paralysis, same side, or there are going to be ipsilateral cortico-spinal signs. And number 5, remember bull. Below level of lesion, it is a upper motor neuron paralysis, and at level of lesion, it is going to be a lower motor neuron type. So these 5 features are for Brown-Séquard syndrome. Let's look at the next question. Weber-Fechner law. Now, Weber-Fechner law is a law of sensory physiology which explains intensity discrimination of a stimulus. This says that the sensation we perceive, the sensation perceived is not proportional to intensity of stimulus. It is proportional to the log of intensity of stimulus. So in other words, Weber-Fechner law gives us the relationship between stimulus intensity and sensation perceived. This is a law for intensity discrimination. There is another law for intensity discrimination, which is the Stevens power law. And that tells you that the sensation that you perceive is not proportional to the strength of stimulus or to the log of intensity, but to a power function of intensity, I raised to the power A, where A is a constant. So these are 2 laws, Weber-Fechner law and Stevens power law, for intensity discrimination of a stimulus. So they give us the relationship between the sensation perceived and the intensity. Weber-Fechner says the sensation perceived is directly proportional to log of intensity. Stevens power law says that the sensation perceived is proportional to a power function of intensity. Let's look at the next question. A 30-year-old male presents with sudden onset weakness of his right hand. There is a wrist drop, there is loss of sensation over the dorsal surface of the hand. Which of the following is the best explanation? There is a sudden onset of both motor as well as sensory symptoms. In that case, my best answer will be demyelination of the radial nerve causing a slowed saltatory conduction. Why not the others? Inhibition of acetylcholinesterase at the neuromuscular junction. This will cause a prolonged muscle contraction. So that is definitely not the answer. Blockage of voltage-gated calcium channels at the motor end plate. Motor end plate does not have voltage-gated calcium channels. Voltage-gated calcium channels are present at the nerve terminal. Excessive efflux of potassium causing a hyperpolarization of the skeletal muscles, that would affect the skeletal muscles rather than. Now, here is a patient who's got both motor and sensory symptoms. In that case, my best answer here becomes B. A 40-year-old male was watching TV for a few hours continuously with his arm under his head. He now complains of a tingling sensation, inability to move the affected arm. Which nerve fiber is most likely to be affected? The nerve fiber most affected by pressure is type A. And out of the 4 type A nerve fibers, A alpha is the most susceptible to pressure. So just have a look at the susceptibility of the nerve fibers to pressure. It is A more than B more than C, out of which A alpha is the most susceptible. To hypoxia is B more than A more than C. For local anesthetics, little controversial. Our textbooks, especially physiology textbooks, are still saying C more than B more than A, but all latest research articles as well as anesthesia textbooks have said that A is the most susceptible to local anesthetics, followed by B, followed by C. And out of A, it is going to be A gamma, which is the most susceptible. So these are today's questions. A 35-year-old woman complains of unsteadiness while walking and intention tremor in the right hand. The moment you see this term intention tremor, that points towards a cerebellar lesion. She also has dysdiadochokinesia, nystagmus, there is already ataxia. So all these point to a cerebellar disease. Now, please remember, cerebral cortical lesions will affect the opposite side of the body. But cerebellar cortical lesion will affect the same side. So if the problem is in the right hand, the part of the cerebellum which is affected is the right cerebellar cortex. Let's have a look at the next question. It says, why can't a neuron fire another action potential during the absolute refractory period? Now, when you look at the action potential, the resting membrane potential is minus 70 millivolts. I give a stimulus here. There is opening of voltage-gated sodium channels. Influx of sodium causes the potential of the cell to become less negative, from minus 70, minus 65, minus 60, minus 55. The moment it reaches minus 55, which is also known as the threshold potential, or also known as the firing level, at this point, now the opening of the sodium channels is by a positive feedback mechanism. That means influx of sodium causes opening of more sodium channels, more influx of sodium, and we get a sharp upstroke. This is known as the depolarization phase, which is because of opening of voltage-gated sodium channels. The potential reaches 0 and even goes up to plus 30 millivolts. From 0 to plus 30, this is known as the overshoot. Now, what is responsible for the repolarization phase is closure of the sodium channels and opening of the potassium channels. That is the downstroke or the repolarization phase. Now, let's have a look at what happens to the sodium channels. Now, if you look at the sodium channels they have two gates, one towards the outside of the cell, that is towards the ECF, and one towards the ICF. Now, the one towards the ICF is called the inactivation gate. Remember, I for ICF, I for inactivation, and the one towards the ECF is called the activation gate. Now, when a cell is at rest, the sodium channel is in the resting state. Now, what is resting state? In the resting state, the activation gate is closed and the inactivation gate is open. Obviously, if one of the two gates is closed, there will be no sodium influx. When I give a stimulus, the activation gate of the sodium channel will open and sold. The inactivation gate was as it is open. So now sodium influx will happen, and this is responsible for the upstroke. This is known as the activated state of a sodium channel. Now the first gate to close is the inactivation gate. So the inactivation gate closes, activation gate is open. Again, there will be no influx of sodium. This is known as the inactivated state of a sodium channel. And please remember, as long as the sodium channel is in the inactivated state, you cannot open the sodium channel again. To open the sodium channel again, it has to go back to its resting state. And what was the resting state? The resting state is the inactivation gate is open and the activation gate is closed. So please look at the sodium channels once again. Resting state, activation gate is closed, inactivation is open, no sodium influx. Give a stimulus, from resting state it goes to activated state, both gates are open. The first gate to close is the inactivation gate, and as long as the inactivation gate is closed, you cannot open the sodium channel again. That means you cannot generate another action potential. To generate another action potential, the sodium channel has to go from inactivated state to resting state. And what is the resting state? Inactivation gate open, activation gate closed. So going back to this question, it says, why can't a neuron fire another action potential during the absolute refractory period? This is because the sodium channels are in the inactivated state. As long as the sodium channel is in the inactivated state, you cannot open the sodium channel again. You cannot generate another action potential, and that is your refractory period. Now, the absolute refractory period is from the firing level till the repolarization is 1/3 complete. During this phase, if you give another stimulus, you cannot get another action potential. What is relative refractory period? From repolarization 1/3 complete till the start of after depolarization phase. That is called the relative refractory period. During this period, if I give a strong stimulus, I can get another action potential. Why? Because during this period, some sodium channels have already gone from inactivated to the resting state. Some may still be in an inactivated state, but some have gone into the resting state. So another action potential can be generated if I give a second stimulus during this phase, provided the second stimulus is stronger. Let's see the next question. A 65-year-old man presents with personality changes, impaired judgment, and difficulty in initiating movement. And the MRI reveals infarction in the frontal lobe. So which of these areas are likely to be affected? Not the precentral gyrus, because precentral gyrus is motor cortex. Here, the patient has personality changes, impaired judgment. Post-central gyrus is sensory. Only sensory symptoms would be present. Prefrontal gyrus. Now, prefrontal gyrus, or the prefrontal lobe, this is the part which is associated with judgment, with analysis, with certain aspects of your personality. That is all because of the prefrontal lobe. So prefrontal gyrus is the best answer. Broca's area is for the motor aspect of speech. Only motor aspect of speech will be affected, right? That is what we have already discussed a couple of days back. Gives rise to a non-fluent motor or expressive aphasia. Let's look at the next question. Which event restores the resting membrane potential after the depolarization phase of the action potential? That means the depolarization is done. Now, what is responsible for the repolarization? Repolarization is because inactivation of sodium channels or closure of sodium channels and opening of potassium channels. Now, it cannot be calcium channels here. It cannot be activation of the sodium-potassium ATPase. Sodium-potassium ATPase, what is the role? After a few thousand action potentials are complete, sodium-potassium ATPase will restore the ionic balance. It has no role after one action potential, and definitely not a passive diffusion of chloride, which is not possible. So this is because of inactivation of sodium channels and opening of potassium channels. Let's look at the last question. Presents with bradykinesia, resting tremor. So intention tremor is cerebellar disease. Resting tremor, pill rolling movement is Parkinson's. So degeneration of the dopaminergic neurons in the substantia nigra pars compacta. Which of the following taste sensations uses a G protein coupled receptor? So we have to understand that the taste receptors can be divided into two types. These can be ionotropic receptors. Ionotropic, that means they use ion channels for their transduction. Or they can be metabotropic receptors. Metabotropic receptors use G protein coupled receptors. Now there are two taste sensations which are ionotropic, and that is salt, salty taste, and sour taste. Metabotropic receptors, the taste sensations which use metabotropic receptors are sweet, bitter, and umami or umami. What is umami? This is the taste of monosodium glutamate. Right? Monosodium glutamate is present in certain mushrooms, in tomatoes, but of course, you know, the artificial form is known as Ajinomoto, which is added in Chinese cooking, in your packet of chips. So you have that monosodium glutamate. So that means now sour and salty, these are ionotropic receptors. Umami is metabotropic. Salty is ionotropic. Umami metabotropic. So out of this, the answer is going to be umami or umami. So just a brief look at what are the receptors. For salt and sour, which are the ionotropic receptors, channels are involved, such as epithelial sodium channels, such as for the sour taste, you have epithelial sodium channels, you have K+ sensitive channels, HCN channels. So different kind of channels are going to be used. For sweet, bitter, and umami, which are metabotropic, that means they use G protein coupled receptors, there are something known as, for sweet, T1 family, T1R1, T1R2, T1R3. So that is transient receptor potential. To remember this, sweet has got one T, so T1. And if you look at bitter, bitter has got two T's, so T2R family. That's how I remember this, right? So these are some special type of channels called transient receptor potential channels, and their names are given as T1, T2. So remember T1 for sweet, because sweet has got a single T, and T2 for bitter, because bitter has got two T's. And umami, you have something known as a glutamate receptor, because umami, I told you, is your monosodium glutamate. And the receptor is mGlu-R4. But these are all three of these are G protein coupled receptors. Now the next question I've asked you on taste. The primary gustatory cortex is located in which of the following regions? Now, the gustatory cortex is in the insula and the frontal opercular cortex. Remember, precentral gyrus is the motor cortex, right? This is for taste, it is going to be insula and frontal opercular cortex. Now, if you look at the taste pathway, so just a brief look, though this is more of anatomy, but we will do this. Taste from the anterior 2/3 is going to be carried by the chorda tympani and the facial nerve. Taste fibers from the posterior 1/3 will be carried via the 9th nerve, and taste fibers from the other areas by the 10th nerve. They go into the nucleus of tractus solitarius in the medulla. Nucleus of tractus solitarius, please remember, is the sensory. So the fibers first enter into the nucleus of tractus solitarius. From here to the ventero-posteromedial nucleus of the thalamus. This is a question which I've asked you earlier, which is the thalamic relay nucleus for taste. This is ventero-posteromedial. And finally, the taste fibers will end in the anterior insula and the frontal operculum in the same site, ipsilateral frontal cortex. Now, what is the insula? So, insula is an area which is deep in the lateral sulcus. This is the lateral sulcus, and here you have the insular cortex. Now, insular cortex is concerned with taste, with visceral sensations, autonomic control, vestibular functions, equilibrium. So, you have to remember the taste fibers will end in the insula. Let's look at the next question. Which of the following ion movements is responsible for the rapid depolarization? Now, this is a question which all of you should have answered. And I particularly wanted 100% correct response in this, but unfortunately, there were 9% of you who marked it incorrectly. So be very, very careful. Read the question carefully. This is something which you have done. The upstroke or the depolarization phase is due to opening of fast voltage gated sodium channels or an inward movement of sodium. The repolarization is because of closure of sodium channels and opening of potassium. And once the potassium channels open, there is an outward movement of potassium. So this has to be absolutely clear. Let's look at the next question. Now, in this question also, I expected 100% response. But again, there are 12% of you who have marked this incorrectly. So again, Golgi tendon organ is a receptor for muscle tension. Which is a receptor for muscle length? That is the muscle spindle. When I look at the Golgi tendon organ is a receptor for muscle tension. It gives rise to what is known as the inverse stretch reflex. Now, what is this inverse stretch reflex? Whenever there is an increase in the muscle tension, the Golgi tendon organ will be stimulated, and sensory fibers from the Golgi tendon organ are 1B. They enter into the spinal cord. In the spinal cord, they will synapse with an inhibitory interneuron, and this inhibitory interneuron will inhibit the A-alpha motor neuron, which goes to that same muscle. So what is going to be the response? If the A-alpha motor neuron is inhibited, the muscle will relax. So response is a muscle relaxation. This is your inverse stretch reflex. Receptor, Golgi tendon organ. What stimulates the Golgi tendon organ? Increase in muscle tension. Muscle stretch leads to a direct increase in the firing rate of which of the following neurons? Now, whenever we talk of increase in muscle length or stretch, the muscle spindle is stimulated. For example, if you're doing the knee jerk, yes, you will use your hammer and you will tap on the tendon of the quadriceps muscle just above its insertion into the tibial tuberosity. When you tap the tendon, there is an increase in muscle length. If there is an increase in muscle length, the muscle spindles which extend from tendon to tendon and are in parallel to the muscle fibers will also be stimulated. The sensory fiber from the muscle spindle. Sensory fiber from the muscle spindle is 1A and 2. These enter into the spinal cord and they directly synapse with the A-alpha motor neuron, which goes to that same muscle. This results in a muscle contraction. And if you remember, when we do the knee jerk, what is the response? The leg moves forward. There is a contraction of the quadriceps muscle and the leg moves forward. right? So this is your stretch reflex. So muscle stretch leads to a direct increase in the firing rate of which of the following neurons? The sensory neurons will first be stimulated and then the motor neuron, which is A alpha. So my answer here will be group 1A fibers. Of course, it's 1A and 2, but answer here becomes 1A, not 1B, because 1B is from the Golgi tendon organ. So if you look at this little table which I've made for you, this becomes important. Stretch reflex, also known as the myotactic reflex or the deep tendon jerks. Stimulus is an increase in muscle length or stretch. Receptor is the muscle spindle. Sensory fibers are 1A and 2. Center is the spinal cord. Efferent or the motor arm of this reflex is A alpha. Response is a muscle contraction, and this is a monosynaptic reflex. Inverse stretch reflex, also known as autogenic inhibition, Golgi tendon organ response, stimulus increase in muscle tension, receptor, Golgi tendon organ, sensory or afferent of this reflex is 1B, center, spinal cord, efferent or motor arm of this reflex is again A alpha, but here the A alpha is inhibited and the number of synapses is 2. This is a bisynaptic reflex. Remember this one little chart, and this will help you answer all questions on the stretch reflex and the inverse stretch reflex. A professional pianist suffers a left medial temporal lobe stroke. He now struggles to remember names of musical pieces, but he can still play the piano. Which of the following is preserved in this patient? So there are 4 terms which are being used here: semantic memory, episodic memory, working memory, and procedural memory. So what are these different types of memories? Now the 2 main types of memories are declarative or explicit and non-declarative or implicit. Now what is declarative memory? What you declare, what you can tell me or what you declare, right? For example, if I ask you, what was your best friend's name? Your best friend in school, what was his name? So that is you're able to tell me. So that becomes declarative. Declarative is of 2 types. There is called semantic and episodic. Semantic refers to facts and episodic is events. Semantic memory involves the temporal lobe and the prefrontal cortex. Episodic memory especially involves the hippocampus, the medial temporal lobe, and the neocortex. Now, what are the types of non-declarative or implicit memory? The first is procedural. Any skill or habit, like in this case, playing the piano is a skill. So that is a procedural memory. It is an implicit. Then priming and perceptual. Now, what is priming and perceptual? Your ability to recognize a word because of prior exposure. That is called priming and perceptual. That means you're answering when you are given a hint. For example, I can say there is a 6-letter word. It starts with S. And it ends with L. And this is where we went to when we were children. All of us went here. And that is a school. So that becomes priming and perceptual. Associative learning, which are conditioned reflexes, if you remember that Pavlov's conditioned reflex. And non-associative are habituation and sensitization. Here, habituation refers to the reflex pathway. We did yesterday stretch reflex, inverse stretch reflex. So all reflex pathways are a part of your implicit memory. Now, let's go back to the question. Now it says, if he's able to play the piano, but he's not able to give you names, that means he's lost his semantic memory. What he has retained is his procedural memory. Procedural memory, or this is an implicit memory. That means skills and habits. Now, what is working memory? Working memory means, for example, when you ask somebody for their phone number, right? Or you ask somebody's phone number and you remember the number while you are sort of typing it on your phone, but you forget after that. That is working memory. You remembered it while you were performing that task. That is working memory. So these are your different types of memory. Important topic from a NEETPG point of view. Let's look at the next one. A 6-year-old boy's lunchtime in school is scheduled at 1 p.m. daily. It is noticed he begins to salivate every day just before his lunch is served. This is best explained by which of the following mechanisms? This is known as a conditioned reflex. Yes, what is an unconditioned reflex? If you remember the Pavlov's experiment, when he placed food in front of the dog, there was salivation. Yes, this is known as an unconditioned. Unconditioned means this is the reflex he is born with. Right? So that is an unconditioned reflex. Give food to a dog and he salivates. Then there is ringing of the bell and you give food, he salivates. This is still unconditioned because he's salivating not to the sound of the bell but to the food. Then when you only ring the bell, there is salivation. That is known as a conditioned response. That means he has learned to associate two types of stimuli here. Ringing of the bell, he has associated with food, and that is why salivation. Right? So if you just ring the bell and he salivates, that means it is a conditioned response. This is the exact picture. Food in front of the dog, salivation. This is unconditioned. Ring the bell, there is no response. Ring the bell, give the food, it is still unconditioned. When does it become conditioned? When you only ring the bell and he salivates. Let's look at the next one. A neurologist is testing postural reflexes in a child. When the child's head is held passively flexed while in a quadrupled position, yes, that means all his four limbs are on the ground, like when a baby is crawling. The arms flex and the legs extend. The center for this reflex is which of the following? Now, this is a typical reflex which is called a tonic neck reflex. What is tonic neck reflex? If you change the position of the neck, there is a change in posture. And the receptors for this reflex are the neck proprioceptors, right? Which will detect the change in position of the neck. And what is the response that you see? The response will be if the neck is flexed, then his upper limbs will flex and the lower limbs will extend. But if the neck is extended, then his upper limbs will extend and the lower limbs will flex. So change the position of the neck and there is a change in the posture. This is called a tonic neck reflex. Yes. And what is the center for this reflex? The center is the medulla. This is a medullary reflex. Yesterday we did stretch reflex and inverse stretch reflex. Those are spinal reflexes. This is a medullary reflex. The reflexes which are integrated in the midbrain are called writing reflexes. Writing reflexes are writing of posture, correction of posture. That is a midbrain reflex. So let's have a look at this little diagram here. It shows you when the baby's neck is extended, his upper limb is extended, lower limb is flexed. When the baby's neck is flexed, his upper limb is flexed and lower limb is extended. Then if I turn the head of the baby to one side, the upper limb on that side will extend and the opposite side will flex. So that is known as a fencing posture. This is the fencing posture, right? So this is your tonic neck reflex. Now, the important thing to understand is that this reflex can be demonstrated in a child less than 12 months of age. If this reflex persists beyond 12 months, that means there is some neurodevelopmental abnormality. For example, this can be demonstrated in children beyond 12 months if there is cerebral palsy, right? So what is the physiology behind this? See, till the corticospinal tract is not myelinated, cortical control is absent. And when do the corticospinal tracts myelinate? When the child is approximately 12 months of age. So that means cortical control is not present till the age of 12 months. Once the corticospinal tract is myelinated, then cortical control comes up. Now, when the cortical control is present, it suppresses the reflexes of the lower areas. Right? When the cortical control is lost, then these reflexes will become unmasked. Right? So you must remember, in a child less than 12 months, cortical control is not present and you're able to demonstrate these reflexes. Beyond 12 months, if this reflex persists, that means there is some neurodevelopmental problem. After 12 months, we should not be able to elicit this reflex in a child. So please remember, I was asking you about the center for this reflex. So center will be the medulla. Let's look at the next question. Which of the following extrapyramidal tract functions like the pyramidal tract? Now, the descending tracts, the motor pathways, can be divided into two. There are medial descending tracts and there are lateral descending tracts. Medial descending tracts are meant for control of the axial muscles. They are meant for tone and posture. And the lateral descending tracts are meant for distal muscles. And these are meant for fine skilled movements. These are meant for fine skilled movements. There are two of these lateral descending tracts. Number one is a lateral corticospinal tract, which is also known as the pyramidal tract, and the other is the rubrospinal tract. The medial descending tracts are four. There is anterior corticospinal, vestibulospinal, tectospinal, and reticulospinal. So now the question says, which extrapyramidal tract behaves like the pyramidal tract? So this will be my rubrospinal. It is extrapyramidal. It is not pyramidal. So it is an extrapyramidal tract behaving like the pyramidal tract. So my answer to this becomes rubrospinal. It is a lateral descending tract. An electrode is used to electrically stimulate a part of the brain which results in hyperphagia, rage, and aggression. This is likely to be which of the following? And your answer to this, which is your rage center, which is your hunger center, is the lateral hypothalamus. So if I use an electrode to stimulate this part, the animal will demonstrate rage, violent behavior, aggression, and will have hyperphagia and even thirst, because lateral hypothalamus is your hunger center, it is your thirst center, it is your rage center. Rage, or also known as the punishment center. Ventromedial hypothalamus is my satiety center, also my reward or pleasure center. Preoptic nucleus, along with the anterior hypothalamus, this is my heat loss center. So it is involved in temperature regulation. This part of the anterior hypothalamus and preoptic nucleus helps to maintain body temperature, especially in summers. Posterior hypothalamus is my heat gain center. So this helps to maintain body temperature when the surrounding temperature, when the environmental temperature is low, that is in winters. So as you can see over here, this is an important table. Hunger, thirst, rage, aggression, lateral hypothalamus. Satiety and reward, ventromedial hypothalamus. Heat gain center, posterior hypothalamus. Heat loss center, anterior hypothalamus, including the preoptic nucleus. Circadian rhythm has been asked as a question, suprachiasmatic nucleus. For sexual activity has been asked as a very old question, anteriormost and posteriormost portions of hypothalamus. Neurosecretion, supraoptic nucleus for synthesis of ADH, and paraventricular nucleus for synthesis of oxytocin. So these were your CNS questions. An important topic from the NEETPG point of view is the thalamus. Now, as far as the thalamus is concerned, it is known as the grand sensory relay nucleus. What does that mean? That means all sensations, whether it's touch, temperature, pain, visual, auditory, all of these sensations relay in the thalamus. Now, which are the thalamic relay nuclei? These can be divided into non-specific and specific. Non-specific are midline and intralaminar. Now, what does that mean? Now, these non-specific sensory relay nuclei will be stimulated irrespective of the type of sensation passing through the thalamus. It could be a somatic sensation, it could be one of the special senses. Specific. The first specific nucleus is ventero-posterolateral. This is for somatic sensations. Pain, touch, temperature. Both the dorsal columns as well as the spinothalamic tracts relay in the ventero-posterolateral nucleus. The second one is LGB, lateral geniculate body. This is the thalamic relay nucleus in the visual pathway. Remember, L for light. MGB, medial geniculate body. This is the thalamic relay nucleus in the auditory pathway. Remember, M for music. Ventero-posteromedial. This is the thalamic relay nucleus for taste. For olfaction, mediodorsal thalamic, or also known as dorsomedial. So the answer to this question becomes very simple. That is D, ventero-posteromedial. This is the thalamic relay nucleus for. So let's look at another important topic in CNS, and that is the cerebellum. Now, this question says a patient with a history of road traffic accident develops an alcoholic gait and nystagmus. Which of the following lobes of the cerebellum is likely to be affected? Now, when you look at the parts of the cerebellum has three major divisions. The oldest in terms of evolution is the vestibulocerebellum. This consists of what is known as the flocculonodular lobe. Nodulus is medial and lateral is the flocculus. Together they are known as the flocculonodular lobe. And the function of the vestibulocerebellum is balance, or also written as equilibrium, and eye movements. Two very, very important signs of cerebellar disease are ataxia and nystagmus. And what is the type of gait that you see in a cerebellar disease? Drunken gait, alcoholic gait. The second part of the cerebellum is the spinocerebellum, and the function of the spinocerebellum is a motor coordination. And as you can see in this diagram, the spinocerebellum has a medial vermis. The medial part of the spinocerebellum is meant for control and coordination of the axial muscles, and the lateral part of the spinocerebellum is meant for control and coordination of the distal muscles. The cerebrocerebellum, or the lateral lobe of the cerebellum, this is meant for motor planning. So the answer to this question becomes pretty simple, and that is the lobe which is likely to be affected is the flocculonodular lobe, or the vestibulocerebellum. So let's look at today's quiz question. The first question today is: a 15-year-old boy meets with a motorbike accident. CT of the brain shows an injury to the posterior end of the superior temporal gyrus. Now, he is likely to suffer from which of the following? Now, posterior end of the superior temporal gyrus is the Wernicke's area. And Wernicke's area, we know, is involved in the comprehension of not just the spoken word, but also the written word, of speech as well as the written word. So the kind of aphasia this patient is likely to suffer from is the Wernicke's aphasia. And if we quickly have a look at this next slide, this tells us where is the Broca's area. Broca's area is in front of the inferior end of the motor cortex. The Broca's area is involved in the motor aspect of speech. So a lesion of the Broca's area will result in what is known as a non-fluent or a motor or an expressive aphasia. That means the patient will not be able to speak at all. Whereas a lesion to the posterior end of the superior temporal gyrus, which is the Wernicke's area, will result in lack of comprehension of speech as well as the written word, but he will be able to speak, though the speech will be nonsensical, full of jargon. That is known as a fluent aphasia. A lesion to the angular gyrus. Angular gyrus is involved in the processing of visual information, of the written script as well as pictures. A lesion to this area results in an anomic aphasia. For example, if you show the patient a picture of a bus, he will not be able to name it. That is, he will not be able to process that picture. That is called anomic aphasia.